video we'll discuss about CSF rhinorrhea. It is leakage of CSF through the nose, right? If it leaks through the ear, then it is called as otorrhea, right? CSF otorrhea. You know that CSF is clear watery fluid which is present around the cerebral hemispheres in the spinal cord also. It provides cushion and acts as lubrication for cerebral hemispheres, right? And then coming to the etiology, the most common etiology of CSF rhinorrhea is nothing but maxillofacial trauma. 80% of the cases is due to maxillofacial trauma. In trauma, no E fractures, that's it, naso-orbito-ethmoidal fractures and posterior table frontal sinus fracture. That is, in frontal sinus we have anterior table and posterior table. If there is fracture of posterior table, then there are high chances of getting CSF rhinorrhea. Then skull base fractures, you can see battle sign, that is ecchymosis in the mastoid process region, right? In skull base fractures you can see the CSF rhinorrhea or CSF otorrhea also. Lympho 2 and 3 fractures and ZMC fractures and fractures of the petrous part of the temporal bone, petrous portion of the temporal bone, right? It will lead to the CSF otorrhea. So these are the fractures which are highly concerned with the CSF rhinorrhea. Then the second cause is iatrogenic, that is sinus or paranasal sinus surgeries and also skull base surgeries. Any tumors involving the skull base, removal of those tumors may lead to the CSF rhinorrhea. And FES, that is functional endoscopic sinus surgery. Okay, these are the iatrogenic surgeries which may result in CSF rhinorrhea. Then third one is spontaneous, that is due to the cellular masses, that is tumors eroding through the skull base or hydrocephalus or osteomyelitis of cranium may result in the spontaneous CSF rhinorrhea. Then there is fourth cause, idiopathic, right? Most common is the most important one is the maxillofacial trauma, and after that iatrogenic, spontaneous, idiopathic. There are 4 causes. So due to the trauma, if the there is fracture of the cribriform plate, then it will result in CSF rhinorrhea. So if the fracture is undisplaced after 48 hours or after 1 week, mostly CSF rhinorrhea spontaneously cease, right? If there is unstable fracture, in those cases there is persistent leak. First, the important topic here is to understand the anatomy of the ethmoidal bone, right? Ethmoidal bone situated in between the 2 orbits. It is a single bone, that is unpaired bone situated in the midline, right? It forms part of the anterior cranial floor, and it forms roof of the nose also, right? You can see in this diagram, this is the cranial floor view, right? That means axial view. Okay, axial means cutting like this, section like this will result in the axial view, and this is cranial view, that is cranial view nothing but sectioning like this, and this is the sagittal view, that means midline sections are parallel, but sectioning like this is called as sagittal view, right? In this case, this is the anterior part and this is the posterior part, right? So this is nothing but the perpendicular plate of the ethmoidal bone, which forms a part of the nasal septum. You know that nasal septum is formed by the bony nasal septum and cartilage nasal septum, right? Bony nasal septum is formed by perpendicular plate of the ethmoidal bone and also vomer. You can see in this diagram, right? This is the ethmoidal bone, this is the perpendicular plate of the ethmoidal bone forming the posterior aspect of the nasal septum. In posterior inferior view, we have the vomer. This is the vomer. These are the 2 bones which forms bony nasal septum, and anteriorly it is formed by the cartilage, right? This is nasal septum view, and in this case also, this is the crista galli and this is the cribriform plate. We'll see in this view. So in this diagram, this is the perpendicular plate of the ethmoidal bone, and this is the crista galli. Crista galli serves as a attachment to false cerebri, that is dural fold. Dural fold attaches at crista galli. In lateral aspect, surrounding the crista galli is the cribriform plate. It is porous in nature. These complete blue color dots are nothing but porous nature of cribriform plate. Because in these pores, the olfactory nerves, that is cranial nerve 1, right? It is a specialized sensory information regarding the smell. So cranial nerve enters the roof of the nose through this cribriform plate, right? Laterally, we have anterior ethmoidal sinuses, middle ethmoidal sinuses, and posterior ethmoidal sinuses. So this is regarding cranial view, which forms a part of the floor of the cranium anteriorly, right? Anterior cranial base. So if you turn this ethmoidal bone upright, right? That means this is the case. That is cranial view. This is nothing but crista galli, what we have seen here, right? And these are the cribriform plates, and this is the middle one is the perpendicular plate of the ethmoidal bone, this one, right? And we have ethmoidal, anterior ethmoidal, middle ethmoidal, posterior ethmoidal sinuses. As I told, this ethmoidal bone is unpaired bone, right? And it is situated in midline between the two orbits. These are the orbits. And this is the part of the ethmoidal bone which forms the medial wall of the orbit. You know that medial wall is formed by number of bones. If you say it is lacrimal bone or ethmoidal bone, like that. So this medial wall forming part of the ethmoidal bone is called as lamina papyracea, because it is very much thin and porous. Because we have already these ethmoidal sinuses, that is why it is papery. This is very much thin and porous, that is why it is called as lamina papyracea, right? This is all about ethmoidal bone anatomy. So if there is fracture of cribriform plate of the ethmoidal bone, that means if there is fracture here, this part, right? Fracture involving this cribriform plate like this, right? So if there is fracture of cribriform plate, there is direct communication of, this is nothing but nose, this is nothing but completely nose. We have surrounding, this is the nasal cavity like this, right? So if there is fracture of cribriform plate, there is direct communication between the nose and the cranium. So if this fracture is undisplaced, then there are less chances of CSF rhinorrhea, or if there is CSF rhinorrhea, then it will spontaneously cease after 48 hours. But if this fracture is displaced, then there is high chances of getting persistent leakage of CSF rhinorrhea. This is all about anatomy, and we have to write these diagrams also. Then coming to the clinical presentation. Clinically, the most important thing is nothing but clear watery discharge from the nose. This is the most important clinical feature. Clear watery discharge from the nose, right? And this discharge is more or increased discharge is seen during the morning, because once the patient wake up from the sleep, then the CSF collected in ethmoidal sinuses or sphenoidal sinuses will get discharged through the nose, right? That is called as reservoir sign. We'll see later. And there is anosmia, because there is fracture of cribriform plate, that will indirectly cause damage or paresthesia of the olfactory nerves. So he can't smell. That is called as anosmia. And there is salty taste also, because CSF is rich in sodium. So it will result in the salty taste. These are the clinical features, not much there. Then We'll discuss diagnosis and management now. There are number of tests and criteria to be used in the diagnosis. The first one is history and salty test. History of any trauma, that is especially fractures of cribriform plate of the ethmoidal bole associated with along with dural tear, that is dura mater tear, right? Then salty test, as I explained earlier, and clinical fluid examination. The first one is reservoir sign. Reservoir sign is nothing but when the patient lies in supine position, the CSF collected in ethmoidal sinuses and sphenoidal sinuses. When the patient turns upright, that means when patient wake up, there will be increased CSF drainage through the nose. Okay, that is called as reservoir sign. And handkerchief sign. Handkerchief sign is nothing but if you collect the discharge on the handkerchief, if it is nasal secretion, that will become stiff. That means handkerchief will become stiff. If it is CSF, then it will not dry and handkerchief will be smooth only. It will not become stiff. Okay, that is most important thing, handkerchief sign. Then target sign or ring sign or hollow sign, or it is also called as double ring sign. That means if we collect the discharge on a filter paper, the blood will form a central ring surrounded by the CSF. Okay, in the center there is blood because the blood is high in viscosity. That is why it is collected centered, and surrounding one is the CSF, right? One ring is formed by blood and another ring is formed by CSF. That is called as double ring sign or hollow sign. Then tramline track from the nose. This is nothing but the high viscosity blood will flow in center, surrounded on both sides by the CSF, right? This blue color is nothing but CSF. So it forms a tramline track. And clinical bedside test, that means if you inject 5% fluorescein intranasally, that is if you place topical 5% fluorescein intranasally, it will turn yellow to green. Okay, if there is CSF, it reacts with the CSF and turns its color yellow to green. Then another one is Quickenstead test. This is nothing but a pressure on the bilateral jugular veins will increase the rhinorrhea. If you apply pressure bilaterally on jugular veins, that will increase the discharge of CSF, right? That is called as Quickenstead test. Then coming to the laboratory test, glucose oxidase test. This is the test to detect the glucose in the discharge. This is also called as dipstick test. Then glucose content and protein content, because there is the difference between the CSF and nasal secretions. When you come to glucose content, it is high in CSF when compared to the nasal secretions. When you see protein content, it is high in nasal secretions, low in CSF. This is very much, these 2 points are very much important, can be asked for PG question. Glucose is more in CSF, less in nasal secretions, and protein is less in CSF, more in nasal secretions. Then the most important thing is the beta-2 transferrin. This is the specialized thing which is present only in cerebrospinal fluid and perilymph, that is fluid in the inner ear, that is middle ear, inner ear, okay, and humor, aqueous humor, that is present in the globe. So in these 3 areas only it is present because it is secreted by the neuraminidase activity in the nervous system, that is in the brain, right? So if you test for presence of this beta-2 transferrin, this is the highly suggestive of CSF rhinorrhea. That means if it is detected in the discharge, then definitely in the absence of open globe, it will be definitely lead to the CSF rhinorrhea. And imaging, you can take the CT, MRI or contrast enhanced CT scan. In CT scan we have to take the axial views and coronal views, right? So the contrast agent utilized is the metrizamide. these imaging techniques useful in the cases of localization of dural tear or localization of CSF rhinorrhea point, so that we can plan for surgical repair in cases of persistent leak. Right? These all are considered under the diagnosis. Now we will discuss about the management. So management, this is the management flow chart. If there is traumatic CSF leak, by the history of trauma like that, we have to first confirm the CSF leak by doing beta 2 transferrin test. This is confirmatory test for CSF leak. Once you confirm, first we will manage conservatively by medical approach with bed rest. We should advise the patient to take bed rest with slightly head elevated position, 30 to 40 degree, right? And we can give the acetazolamide, which decreases CSF production, thereby decreasing the CSF pressure. So improving chances of CSF stop, CSF rhinorrhea stop, right? And we should advise the patient not to sneeze, not to cough. These are the activities which will increase the CSF pressure, thereby increasing CSF rhinorrhea. So this is medical management, and we should observe the patient for 72 hours. After 72 hours, if the CSF leak stopped, most of the cases, CSF leakage will stop spontaneously with some amount of conservative approach. So if it stops, then we have to observe the patient. If fail to cease, then we should go for lumbar drainage, right? That means in lower back region, we have to place the drains in subarachnoid space to drain the CSF. So once the CSF is drained, then the CSF pressure will decrease, thereby improving chances of CSF leakage stop, right? So after lumbar drains, this should be placed minimum of 4 to 5 days. So if there is leakage stop, then we should observe the patient. If there is persistent leakage, that means above the 8 days from the time of trauma, if there is persistent leakage more than 8 days, then we should go for intrathecal fluorescence for fistula localization. That means if there is persistent leakage more than 8 days, then we should go for surgical therapy, surgical repair of dural tear along with the grafting. So for surgical repair, before that we have to localize the fistula, where the exact opening. That is done by intrathecal fluorescence. Intrathecal is nothing but injecting in subarachnoid space. So intrathecal fluorescence will localize the fistula area. After that we have to go for surgical repair of dural tear along with the grafting. Grafts which can be used includes fascia lata graft and pericranium graft, and we can use the fibrin glue also. That means we should pack the area with these grafting. In surgical approach, we can do it intracranially or extracranially. Intracranially is nothing by doing the craniotomy. That is making a opening in the skull. By that approach, you can go for the surgical repair of the dural tear. We should suture the dural matter, right? Then in extracranial thing, you can use external ethmoidal sphenoid approach or transsphenoidal approach. The exact procedure is not much important to us because almost these procedures are taken by the plastic surgeon or cranial neurosurgeon, right? So not the detailed procedure is not important to us, but basics we should know, right? In ethmoidal and sphenoidal approach, we'll make an incision in the medial wall of the eye. From that incision, we can repair the dural tear, right? If it is non-traumatic CSF leak, that means because of any cranial tumors like that. So first we have to go for MRI to rule out what is the underlying pathology, and we should manage accordingly. That means if it is cranial tumor, then we should go for tumor excision. That is again the procedure of neurosurgery. So not that much important, but the basics we should know. This is all about management of CSF rhinorrhea. If you like this video, hit the like button, share the video, subscribe the channel.